So I will talk to you about an interesting case that we had in Sherbrooke, but this is also a case that you can encounter in your clinical practice not that infrequently. So, yeah. So I will present you the case briefly in order to maximize the time for interaction at the end between the audience and the panelists. So this is a 85-year-old man known for symptomatic severe ES, New York Heart Association Class 3. His left ventricular ejection fraction is 55%. Peak and mean gradient are 68 and 39, respectively. Index aortic valve area is 0.49. So he presented to us in 2012 for an elective cardiac cath in order to complete his AVR workup. So at this time, the past medical history was significant for a recent hospitalization for cardiac failure. In fact, that was at the time that the severe ES was discovered. He was principally known for chronic AF, so he was anticoagulate with warfarin. His INR were quite stable, with 1 INR performed a month. So his CHADS-2 was 4, his CHADS-VASc was 5, and his ASBED was 3. He was typically known for type 2 diabetes, hypertension, dyslipidemia. There was a mild abdominal aneurysm. His kidney function was quite good, with an eGFR of 65. He had mild asthma, and in 2007, he presented with upper GI bleeding secondary to a peptic ulcer that was clipped. So here is the cardiac cath. So on the left side, you can see the osteal, or maybe we can, so maybe we could start again, yeah, just to appreciate the left main osteal lesion. Yeah, if you can clip it. Or just come back the slide before and we're gonna play it again. Yeah, great. So there is an osteal left main disease, and on the right side you can appreciate the mid-LED lesion. The mid-LED lesion is indeed a bifurcation lesion with the first diagonal, which is normal. And you can see on the spider view the osteal left main disease. On the right system, there is an aorto-osteal disease. This is a 4 French catheter, just to figure out. And this is an aorta angiography that reveals some moderate to severe calcification of his ascending aorta. So when we calculated his coronary artery disease burden, his syntax score was 43. His syntax score 2 revealed a 4-year mortality of 24% with PCI and 56% with CABG. We completed the workup with thoracoabdominal CT that confirmed the porcelain aorta. His femoral arteries were quite good, with diameter of 8 millimeter on each side, with no significant tortuosity and calcification. So at that time, we calculated the STS score for SAVR plus CABG at 9.3%. His CATS index for frailty was 6 out of 6, so pretty good for an 85-year-old man. So the patient underwent a heart team discussion together with the geriatric, the cardiac surgery, and the interventional cardiologist. So the patient was deemed not operable due to the porcelain aorta and the iris surgery. So at that time, we elected to do a stage procedure, so do the PCI first and do a TAVR through a transfemoral approach in the second time. So here's rapidly the PCI of the left main and the LED. So we balloon the proximal LED, balloon the left main. The stent was not able to get in, so we do some cutting balloon on the proximal to mid LED and cutting balloon in the left main. Finally, the stent won't get in, and we put another stent in the mid LED with pretty good result. And then we fix the right, we balloon, put the stent in, and do a post-dilatation. And as you can see, there is a mild residual disease in the right. So the procedure resume, so we used a 7.5 radial sheetless guiding. So we use in total 3 drug-eluting stents with the stent diameter in total after post-dilatation 4.0 in the left main, 3.5 in the LED, and 3.5 in the RCA. So the total stent length is 58 millimeter. There was no bifurcation lesion, no CTO at all, and his residual syntax score was 7. So for the sake of the discussion, so in this patient, 85-year-old gentleman, AF CHADS 4, CHADS-VASc 5, ASBLED 3, we underwent a PCI of the left main, and we scheduled for a TAVR as a stage procedure. What would you do? Would you do a triple therapy, and if yes, would you use DOAC? and of any duration, 1 month, 3 months, 6 months. And does the pioneer FPCI and the leader-free trial in this particular case will influence your treatment selection strategy? And just for the sake of a discussion, if we switch the ostial left main disease for a distal left main disease and we need to treat with bifurcation with 2 stents, how this will impact your selection strategy. So maybe we could start with the panelist discussion.
I'd say Jean-Bernard or Eric. It's a left.
I'm reluctant to drop either of the antiplatelet therapy in left main stenting. So I would consider any type of therapy that includes dual antiplatelet therapy for 3 months.
3 months, okay. Eric?
I would do the same. I would use the Pioneer with 15 of Xarelto and dual antiplatelet therapy.
Okay, so that doesn't exist in Pioneer, 15, but...
15.
15, okay.
Xarelto 15, but
okay.
add aspirin for at least 1 month, and then see how he does.
Samar?
My only other comment is that the patient had heart failure and a very severe AS, and maybe you could have gone with a less complete revascularization to decrease the amount or the risk of stent thrombosis. You need to do the left main, but everything else is up to discussion, if you ask me.
The subtotal middle AD you would...
Well, it was difficult for me to see, but it was tight. Okay, so left main and LAD then.
Okay.
I think no one will be going to stop any antiplatelet therapy after such a procedure. We will go for a dual antiplatelet therapy. The whole question is for how long. Mm-hmm. The critical period is a month. If he will tolerate it in addition to a lowest dose of NOAC for 3 months, we'll go for it for 3 months, and afterwards single antiplatelet plus NOAC.
And Pentaloc, obviously.
Yeah, for sure. He was already on PPI.
Can I just ask a question? This patient would not, I don't think, have been randomized into Pioneer. So my point would be you can do anything you want, but you can't use Pioneer to help make a decision, right, Shamir?
Well, I guess the exclusion would be the aortic stenosis, which is there, but probably not the primary factor impacting on...
there is no exclusion criteria regarding the angiographic
no,
characteristics.
There isn't.
Successful PCI, you are eligible.
This patient would have been eligible from that.
Yeah.
But I think the AS may have excluded the patient from Pioneer. So, so it shouldn't influence the general discussion about the duration. So, and I like what I'm hearing. I mean, it's pretty consistent. Mm-hmm. People try to say there are all these different strategies and so on, but it's pretty consistent amongst interventional cardiologists in these high-risk cases that most people are reluctant to drop one of the antiplatelet drugs. Is there anybody from British Columbia here? Because I think that may be one province where there may be some differences in management. No? Jackie Saw is probably not online.
Any concluding slide, Etienne?
Yeah, sure. So finally, just to follow with the case description. So at the time we were in 2012, so the Pioneer FPCA was not performed yet. So we elected to do triple therapy for 3 months, aspirin, Plavix, Coumadin, and then drop the aspirin and continue for a year with Plavix and Coumadin. So the evolution was quite good. He underwent transfemoral TAVR 6 months following PCI just because of the waiting list. He underwent a CPNXT. No bleeding nor ischemic complication, but unfortunately he died 3 years later, but due to a septic shock secondary to a polyarticular septic arthritis, but endocarditis was ruled out with 2 serial TEE at that time. So thank you very much.
Dr. Ahmed Bouzid.
So our patient is a 65 years old man with cardiovascular risk factors including type 2 diabetes, hypertension, and dyslipidemia. He's known with coronary artery disease with stable angina treated with PCI of both LAD and first marginal in March 2016. He's also known for chronic moderate renal failure and paroxysmal atrial fibrillation with Schatz-Vask score at 3 and has bled 1. His baseline medication include aspirin, Xarelto 20 milligrams, and the conventional treatment for ischemic heart disease. So 13 months after the first procedure, he presented to emergency department for acute persistent chest pain and in the EKG ST elevation in leads V1 and V2. He was loaded in clopidogrel, and the left coronary angiography showed stent thrombosis of the LAD. So after thromboaspiration, a second drug-eluting stent was implanted in the proximal LAD with good angiographic result. The TTE performed on day 3 showed reduced left ventricular ejection fraction and apical akinesia without thrombotic evidence. So this patient presents paroxysmal atrial fibrillation and now Schatz-Vask score at 4 and very late stent thrombosis on aspirin and Xarelto. So I would like to ask you, what is your antithrombotic and antiplatelet regimen at discharge for this patient?
Can you give us maybe a couple of additional information? What was the time of ischemic occlusion time from the STEMI?
For the thrombotic, for the stent thrombosis, we didn't perform intracoronary imaging.
No. I'm asking, did the patient had an hour of chest pain or 5 hours? And
about 1 or 2 hours of chest pain.
Okay, and how early was this echo done? Like, do you expect some of it to recuperate, or is it cued and you have 5,000 of CKs?
This is a day 2 cardiac ultrasound that was performed after the PCI.
So fairly early.
Yeah.
Okay, so I would like to ask you, what is the best anti-platelet, antithrombotic regimen to propose with this patient? So aspirin ticagrelor or aspirin prasugrel, Coumadin with dual antiplatelet therapy, aspirin clopidogrel or aspirin ticagrelor, NOAC full dose or half dose with aspirin and clopidogrel. So,
just a question. Did you mention when exactly the event happened from the time he actually had a stent? So the stent was there for how long?
13 months.
13 months after the primary week, yes.
Okay. Well, it's kind of tricky, eh? So since he was on Xarelto and aspirin, right, at the time of the stent thrombosis,
aspirin.
he presented himself in ACS. I think my guess would be to stay in conventional triple therapy with that patient, aspirin, clopidogrel, and Coumadin.
Okay.
I think I would be a bit chill to actually try another regimen. Certainly, Coumadin with ticagrelor or prasugrel. We don't have data. I would be scared for the bleeding. I don't know what's the input of the other members of the panel, but.
Yes. I think that triple therapy is no question here. We have to go. The time is a high thrombotic risk, high risk of recurrence. So the longer we feel, that's the kind of patient I would consider maybe 6 months of double antiplatelet therapy on top of Coumadin. And at the end, I would drop the aspirin and keep the Plavix, which is, in my mind, a way more a potent stent medication regarding platelets.
And why Coumadin and not NOACs? We know that NOACs reduce bleeding.
To be honest, before Pioneer, I was a bit the relay data, all that. But right now, I would be fine with NOACs, either NOACs or Coumadin.
Did we actually do imaging just to figure out what was the mechanism of a stent thrombosis?
No, we didn't perform intracoronary imaging.
Thank you.
Philip, I have a question. How long was he on dual antiplatelet therapy for after the first stent? Ahmed, is for you the question.
1 month.
Only one? You mean 1
Yes,
month?
because the first presentation was stable angina.
Okay, so it was treated for 1 month with that, and after that, aspirin and Xarelto.
Yes.
Okay, so he got a stent thrombosis 13 months after the implantation of that stent.
Yes.
And now we're talking about that for 6 months and dropping aspirin or Plavix but what is it going to change in the future and the risk of stent thrombosis of that patient if he already had a very late stent thrombosis? Shouldn't we consider to treat longer than 1 year? And if yes, with what? And what about Coumadin, NOAC? Because 6 months, 3 months, 1 month, fair enough. But he got a very late stent thrombosis. So do we need to extend beyond 1 year? And
You
if
mean,
yes, with what?
you mean the extra, whatever you leave with the Coumadin?
Whatever
yeah.
you leave.
Yeah, yeah. I would.
Would that be ticagrelor at the 60 milligram twice a day? Would it be Plavix? What do you think?
Just to drop the aspirin and leave Plavix and
I
Coumadin?
think no one will take him back to the regimen he had when he arrived with a stent thrombosis, right? No one will keep the aspirin in addition to any anticoagulation. Maybe this patient has some resistance or whatever. But the only thing that we will do here is to keep him on the triple therapy as long as he can tolerate it. If he's fine with it for a year, we'll do it for a year. But at the end, you will need to stop the triple therapy. You can't keep him lifelong on the triple therapy. And when we will decide to stop that triple therapy, my choice here will be to go stopping the aspirin and keep him on clopidogrel. We don't have much data with full dose anticoagulation in addition to ticagrelor, and reimbursement will be an issue with ticagrelor for lifelong on these patients. So my choice will be to put him on full dose NOACs plus clopidogrel as much as he can tolerate it. We know that the bleeding risk is higher than with aspirin, but here is...
So I think bottom line is that we need to change something, right? We're going to try something different.
Yeah.
I think first is we try to do the best we can in the lab, trying to optimize this new stent. Once this is optimized as far as the use is concerned, try the new recipe. The new recipe, I think, is DAPT for sure for a number of months. This is anything between 6 and 12. I don't think I would go any lower than that. And then once this is done, let's say 12. After 12 months, then of course I would also try another recipe than the one that was shown to be a problem. So I would probably, if the patient has tolerated DAPT plus an anticoagulant for 12 months, I would just stop one of the antiplatelet drugs and keep on going with maybe clopidogrel and DOAC, for example.
Yeah, no, I agree. And you know, the patient hasn't had a stroke, so I'm not sure about switching the NOAC. I'm not sure the patient needs warfarin in this situation. So certainly that part of it. What I would do is lower the dose of the NOAC and continue with long-term dual therapy. That for sure. And remember that the stent thrombosis happened on monotherapy, like just aspirin alone. So you know, if you use dual therapy, you'll lower the risk. So this is a good one for the ultra low dose therapy. Now, the ReDual trial will have the 2 doses of dabigatran, the 110 BID and the 150. It'll be evaluating, and then likely we'll have the 2.5 milligrams of rivaroxaban, hopefully within a year. So that'll be an option as well. But I think dual therapy is mandatory for stent thrombosis. A very nice case of that.
Yeah, just to be a little provocative here and to wrap up all the topics of the sessions, there are some centers around the world who would actually consider mechanical protection of thromboembolism here by doing LAA occlusion to allow you to continue to DAPT for a long-term period of time in that specific case. And they are actually less aggressive, not even considering a very complex situation with a lot of ramifications here. And I'd like to open that as an option for this type of patient.
This is very well taken, because this is what we've been discussing, and I think it's very true that this is an option. Because we don't have data for anything, right? But common sense here says that DAPT should be prolonged, and triple threats should not be prolonged.
Don?
The other point that we can bring up, when we, maybe 10 years ago, we were into platelet testing, has fallen by the wayside for the reasons that we know. Now, could this be a case where a role for platelet testing would be important? You know, with Pioneer, we're sort of throwing away the aspirin. We're using this beautiful drug that's called clopidogrel. Well, clopidogrel, you know, when the new antiplatelets came out, was a terrible drug. Resistance, 35% of patients, 50% of patients didn't respond. That's why ticagrelor and prasugrel is the new age. But now suddenly we like it again. So in a case like this, I would feel a little bit more comfortable about testing this patient on Plavix before throwing away maybe aspirin.
But the issue here, Don, that the event did not happen while he was taking clopidogrel to think about resistance. The event happened later on when he was taking the aspirin alone as an antiplatelet therapy.
No, I agree. But one of the strategies that was put forward was, and I agree, you know, we want to have the most drugs on board as long as we can. But then one of the strategies was, well, we would stop the aspirin to minimize bleeding, Pioneer-like. Except that maybe this patient is resistant to Plavix. That would be a disaster. Yeah. You know, there is a problem. Is it biological or mechanical?
But this case really highlights that very late thrombosis is an entity that we don't understand so well. Obviously, this patient was off DAPT for 7 months.
Sure.
And
12
months.
Yeah.
12 months.
Yeah.
So 12 months,
Yeah.
and all of a sudden something happened for no reason.
Yeah. But imagine that patient that we're really worried about, we don't understand, and we put them on a medication that has maybe a 30-40% chance of inefficacy.
Well, it's not entirely clear that this is the case, as you know, right? I mean, the single. I mean, it was shown globally that for a given patient, it's not clear, but for populations, if you treat with a single agent, there is a slight benefit in treating with clopidogrel as opposed to aspirin when you regard all atherothrombotic complications. So it's still a theoretical concern, right? But I don't think that the real clinical events, because this is not entirely clear that when you give the medication chronically, it does express itself the same way as it would in the short term, because you can eliminate resistance if you reload a number of times, right? Most of cases, anyway, if you treat for long enough.
Honestly, it's unfortunate here that the operator did not perform endovascular imaging, because that would help a lot for the long-term management of these patients. If the issue was a mechanical one, and you address it, it will simplify the recipe later on that you will take for the long-term issue. But here we are facing now just the pharmacological management that we can take in this patient, and we are trying to protect him as much as we can. Here, fortunately, that the Hasbled is low, knowing the limitation of the Hasbled, so maybe he will afford a long-term triple therapy before we switch to a
the other thing, would you have had a mechanical explanation, you might have treated properly. You might not have needed another stent in a guy that is thrombosed, that did have a thrombose. So yeah.
Jeannot, do you think you would have put on an LA closure device if the patient was not a bleeder up front, like hasn't actually bled, like in prophylactic indication for that?
Well, it's probably a little bit more difficult to stretch to this kind of indication, but here again, the aim is to be able to treat the patient on a long-term DAPT. Now, whether you want to test, DAPT with a NOAC, but then that the NOAC or the embolic protection that you want to have, also you want to have it on a long-term perspective. So rather you expose the patient to somehow prolonged triple therapy until he has a bleeding, but at the end of the day, you may not want to have this exposure to a significant complication of your triple therapy, and then consider that. I mean, it's certainly an option. So the patient is what, 85? So people would start saying, no, he's 66.
65.
Okay,
65.
the other one was 65. So I think it's reasonable investment for that type of long-term duration of protection in all the sides that you want to have the protection, coronary side and also brain side.
Okay. I would like to just comment on what Samer said, that it's too bad that the echo was not done. Although, you know, I totally agree with you that this would have been informative. It's unlikely at this time that it would be a strong mechanical problem. We're talking about a year after the implantation. The only thing that you may find is a somewhat under you know, expanded stent, but nevertheless that could not solely explain the thrombosis and lead you to decide that, you know, you're going to be more liberal in your dual antiplatelet therapy in the future, because it's not an event that happened like a month or a month and a half after. It's like a year after. So I think we have to think more about, you know, anti-thrombotic management in that case rather than technical issues. And I agree with that's a great suggestion of appendage closure. But I totally echo everyone who says he needs triple therapy as long as we can. But the problem is, like, we're likely going to make a bleed. And at some point, we'll have to drop something, and we'll have to drop the NOAC and put and hopefully he'll survive his bleeding. But that's not always the case.
Just one last comment. This is a type of situation where discussion with the patient is extremely important. Why not expose this option to the patient, and then he knows about the risks of the procedure, which is upfront, but then the risk of triple therapy. So the discussion with the patient in these kind of situations is extremely important, just as we said in the morning where the left main was an issue, where the patient needed to get some input and personal kind of decision-making towards the process, because we're all, you know, very experienced cardiologists around here, and we're kind of debating, but then the patient might be the one just, you know, telling you what the option he's going to prefer will be.
Yeah, okay. I'd like to just bring two additional points. So Samer's comment about imaging at the time of the stent thrombosis, I think, is key. It could be stent under expansion. We could be blaming the stent for an uncovered plaque distal to the stent that ruptured, and we're just seeing the stent being occluded. So imaging would help us understand why this patient had a stent thrombosis. Now, I'm going to be provocative like Jano, but as a coronary interventionalist, and maybe one other option that we could consider is bring back this patient, even though it's not being tested in any trials, but nor as appendix closure for this situation, and re-image him with an OCT in 6 months, a year, to see how the stents have been healing. And maybe if we see excellent strut coverage, our worry about an additional stent thrombosis for which we have no mechanism may be diffused a bit, and we may be more comfortable in leaving the patient with just one antiplatelet agent and a NOAC.
Okay, thank you. So,
okay, very good discussion.
Thank you. So just to say that we decided to discharge patient with aspirin, clopidogrel, and Xarelto 15 milligrams up to 12 months.
And the patient is doing well?
Yes.
Okay.
Okay,
all right, so I think it's a very good discussion. I think this was exactly what we expected as far as evaluating all the options. These are not the guideline type patients, and this is exactly why we want the discussion and the experts expressing themselves. So I think we will conclude the session now. I thank you very much for staying on until that late. We have on the way out, if you guys want coffee or juice or whatever, there's still the poster session that we cut off because this was supposed to be done during the break. If you want to take a look, of course, the two fellows that are there currently would probably appreciate to see at least a few faces looking at their posters. Thank you so much.